Thank you so much. So we are going to move straight to our next panel. And I am very pleased to introduce our moderator for the next panel, measuring the non-medical needs of our communities. I did just want to note, unfortunately, Matt Reidhead, who was supposed to participate in this panel, is not able to be with us, but we will have a fantastic conversation today. Let me now introduce Dr. Adaeze Enekwechi. Adaeze is president of IMPAQ, where her responsibilities include strategic and tactical oversight of all services, including research, technical assistance, and technology services across all practice areas, including healthcare, workforce development, social programs, and more. Adaeze served as the Associate Director for Health Programs at the White House Office of Management and Budget. And as the federal government's chief healthcare budget official, she provided policy management and regulatory oversight for over $1 trillion in spending on a range of federal programs. So she has a really deep understanding of how the system works. She knows a really broad range of issues, and we're thrilled to have her. So, Adaeze, take it away. Thanks.
Thanks so much, Sarah. Oh, mic is on. Good morning, everyone, and thank you so much for joining us for this very important conversation. I am joined here on stage by Dr. Shantanu Agrawal, who is the President and Chief Executive Officer of NQF, and also by Dr. Jamo Rubin, who is the founder and Chief Executive Officer of TAVHealth. Their very impressive bios and resumes are in your folders, and in a minute they will have a chance to say a little bit more about their work and what they do, as well as share their thoughts on data and measurement in the space of social determinants of health. So that's what this panel is about, and I think it's been teed up for us quite nicely by the panel with Dr. Kimberly Dawn and Dr. Joe Thompson. One of the main things we hear in this space is that we don't have the right data. We don't have data to measure social determinants of health, or that the data we do have are largely inadequate. And in my opinion, I think this has led to some amount of paralysis, or at least giving up, because I think people feel frustrated by what some of those data challenges might represent. But I also see an opportunity, but I think that perhaps in exploring that opportunity, we ought to be thinking a little bit more creatively about how we conduct data analysis. But for those of us who are researchers, and even questioning whether we're asking the right questions, one of the issues or points that Dr. Joe Thompson raised is, how are we thinking about the framework? Are we thinking about individual characteristics, or are we thinking about this in a more community-based setting? We are also faced with disparate data sources, so very different data located in very different areas. We have data in census, we've got data in agriculture, we've got data in transportation, housing. All of those don't necessarily talk to each other. So there's a strong argument to be made that we might actually have a good amount of data, a lot of data, we're just not mining them, and we're not using them efficiently to glean the kinds of information we would like to glean. I think I might stop there for now, but I would welcome our panelists to speak a little bit more about some of these broader issues, as well as what they've seen happen, whether it's in health systems, general, different healthcare entities, health plans, and payers. And with that, I will turn it over to Shantanu to share a few words.
Thanks, Adaeze. And I want to thank Sarah and the Alliance for the opportunity to come speak with you all today. So we'll be a little bit interactive right at the outset. How many of you have never heard of the National Quality Forum? And it's okay. This takes a lot of bravery to raise your hands. I get that, especially in front of the CEO. It's cool. Never heard of the NQF. It's all right. Yes. All right. I would believe it if more hands were up, but that's okay. So we are a private nonprofit based here in DC. We're celebrating our 20th year now, and our work and history has primarily been in the areas of quality measurement and improvement. We were actually started 20 years ago from a Clinton administration report that called for the creation of a private entity that would bring more consistency and rigor to measurement and improvement. So we've been working in this space for quite some time, and have also had for probably over a decade a lot to do in the areas of healthcare disparities and health equity. We have 3 strategic priorities that I'm happy to talk through as this goes on. First, very germane to this is all about measurement and data. So we have helped to endorse and create standards around quality measurement for all of the different aspects of healthcare throughout our history. And that's no different when it comes to areas like addressing the social determinants. We believe that in order to really identify populations at risk for these issues, as well as to intervene, you obviously need to pull together the right data and the associated measurement to track your performance and interventions. Second, we are really focused on surfacing interventions that work. And here again, we take a very scientific approach to our work, also a very consensus-based approach to our work. And so we believe we can use those capabilities to identify what the latest research tells us in dealing with the social determinants of health and making it clear that it works and trying to nationalize that as much as we can given our reach. I think it's a basic principle that we have that best practices shouldn't be a mystery to communities and delivery systems interested in implementing them. And third is really thinking through the impact on payment. So there, measures do matter, and we are doing a lot of work in social risk adjustment around measurement, especially as that interacts with payment, but also thinking more broadly about how payment models and approaches can help to resource communities and delivery systems to actually intervene on these disparities. So once we've identified them, once we know what to do, can we actually give and utilize resources in the right way to make a difference. So that is really what we're focused on at NQF in this area, and there's a host of programs and projects that we currently have underway in order to really address all 3 of these strategic priorities.
Great, thank you, Shantanu. Jamo, would you like to share a few words?
Sure. I also thank you all for allowing me to share some time with you this morning. My perspective that I'll offer today is really from the hilltop of the entrepreneur. And the question that we have been wrestling with is, why is everybody talking about all this stuff? I mean, why now? Social determinants is the buzz. It wasn't the buzz a few years ago. When I was in medical school, like many of you all, we never talk about this stuff. We used words like discharge. Didn't know what happened to people when they left. But out in the community, I would imagine there's some that have taken a little bit of offense to even the phrase social determinants of health that's new, when folks have been out doing this work for hundreds of years. Yeah. So what is that, and what is this gap? From my perspective, it kind of fleshing out the root cause helps at least me understand what is the question we're trying to answer. So today, Medicaid is the number 1 or number 2 line item in every state budget. Every election is about health care, period, full stop. In 5 or 7 years, 50% of the country is going to be in Medicare or Medicaid. So this is a money problem. And I don't mean to talk about the lives that we're trying to impact, but the root cause, in my view, of all of this energy around this new thing that's not so new called social determinants of health is the fact that we're running out of money and we need to do something about it. So interstage left, value-based care, an opportunity that's both red and blue. Maybe we get there on different roads, but it's kind of a common end. That's an interesting thing for policymakers. And the end point of value-based care has to accommodate the big levers that we can use to make value-based care successful. The biggest untapped lever for value-based care, social determinants of health. Healthcare's never done anything about it. They were never incented to do anything about it. We know how powerful incentives are. So here we are today. It's the #1 topic in every hospital, in every health plan, in lots of organizations, policymakers, everybody's trying to figure out what it is that we're trying to do. And one of the questions that they passed to us as we thought about coming up here today is how do organizations leverage this data for social determinants? And my first reaction, and I wrote it down, was not well. Not well at all. The silos that we have with data don't only exist in the covered entities of health plans and health systems and providers, but they exist over in the non-covered entity side. There's lots of data silos out in the community. Homeless management information systems don't talk to anybody else. Most of the community organizations don't even have data systems. And then there's the eternal question of interoperability. This is not a technical question. This is not a capability question. Every other industry that has found a reason to be interoperable does it well. Ask Amazon how they're doing. And as a matter of innovation, if innovation always flows to the consumer, we're all super excited about that. So the covered entities and the non-covered entities operate in silos. The federal laws around data sharing and the state laws around data sharing have not kept up with the policies that are promulgating all of this value-based work. The Office of Civil Rights, everybody's scared to death of them. Rightfully so. But a lot of what they manage is not well understood by even the health systems and the health plans. I still know a lot of people that think the P in HIPAA stands for privacy. It doesn't have anything to do with privacy. Matter of fact, it's all about the opposite. But the threat of OCR is so daunting that most of the compliance officers manage against that threat. So my perspective as we go through the rest of this session will be based on that. Why are we doing this right now? And what can we harness about the energy that's driving this national conversation to let this data out and let data do what it's done in every other industry, and that is equalize everything on behalf of the ultimate beneficiary, which are these people that we're trying to help.
Thank you so much. I think you've teed up such a critical point and what I know has been a gap in our field, which is, you know, for those of us who were in training 15, 18 years ago, social determinants was, if you touched on health services research or medical sociology or epidemiology, you knew what social determinants were and you knew the literature dating back 100 years. But as someone who lived in that world, but also worked in health policy, there was a huge chasm. This is a brand new issue, relatively speaking, in the last 3-4 years maybe, with new coalitions and people often talking in ways that are inconsistent with what we know from the literature in terms of what might work or what the expectations would be, or what, quite frankly, what it takes to address these issues, even in pilot phases, let alone at scale. So that's why I think this conversation is so important, and it's one of what I think and hope would be many. One of the questions I want to tee up for you, for both of you, is in that spirit, we've heard about Dr. Kimberly Dawn Wisdom mention the Anchor Network, 43 or so entities, primarily health systems that have formed a group, a collaborative, if you will, where they learn from each other. I'm not sure what the data conversations in that space would be, because when we talk about interoperability, and if you need us to define that, please signal somehow, because I don't want to assume that we're all speaking the same language. But we hear about the Anchor Network. We hear about states. Dr. Joe Thompson is from Arkansas. We hear about new experiments occurring in places like North Carolina, with some other states experimenting or thinking about moving forward and addressing social determinants of health. In your view, with respect to data specifically, what is missing in those conversations? What do you think is the lever we are yet to pull in data? Can you be as specific as possible so that if you're in a position to write legislation or help frame a policy, you have something pretty concrete to grab onto?
So from my standpoint, it's really about granularity of data, right? It's individualizing data down to a person's need. So I think there's more work to do in terms of really even pulling together the data that exists. To your point earlier, Adaeze, there is a lot of healthcare data that we are not making interoperable, that we're not utilizing together. There's also data outside of healthcare that we could be pulling in order to better understand where populations at risk are. But I think a basic limitation of a lot of the existing data is that it really is at the population level. There's lots of great analyses that you can find online and in other places, that shows disparities at the zip code level. And that's important, but it's just not sufficient for addressing an individual's healthcare needs or social needs. We really have to get down to the individual level. It's much like lots of other challenges in clinical medicine. I think it's about developing social risk registries that really get down to the individual level, doing risk assessments at the individual level about what social challenges a person is truly facing. Again, can you imagine being a trauma physician in the middle of West Philadelphia? I trained in Philly. In emergency medicine, we wanted to know data for every single individual that was coming into the ER about the risks that they faced from a trauma standpoint because we were a level 1 center. That's the kind of mentality that needs to be applied to social risk. It's got to be, every single time you interact with a patient, you're asking questions about that so you understand the risk and then you can design interventions that meet your community's needs.
Right.
I would add to that focusing on the question that we're trying to solve as it relates to what's missing in this data. First of all, most of this data is not clinical. This, in no small part, this is not a clinical problem. And for a bunch of health plan provider, payer people to pontificate on data is a head scratcher, with all due respect to all of us and from the clinical world. Because we don't know what this data looks like. We don't have places to put it. And these are broad sweeping generalizations just to make a point. But there is no place in an electronic medical record to put the kinds of things that social workers walk into homes and see. She's got 9 cats and she's lonely. Where do I put that? What do I do with that data? So on the one hand, I think it's important to understand that if the clinical train is coming at social determinants, there are big limitations into the way that we've been thinking about what we do for a long time, that are structural limitations in how we accommodate data. 2, our world is about a patient. And many times this social data is about systems. It's not only non-clinical data, but it's family system data, ecosystem data around who these people are. We don't know how to accommodate information like that. That's the darker side of my answer. The lighter side of my answer is there's lots of data out there. There's lots of information out there. And the kinds of information that's out there around social determinants, if we can, if your goal is to focus on things that are actionable right now, and we're not necessarily going after ocean boiling problems, these are data sets that are relatively simple, not easy, but simple, and actionable. When someone doesn't have money to pay for their medications, that's simple data and it's actionable. And if we can solve that, we don't need a 2-year retrospective double-blind study to know that she didn't buy her medicines because she didn't have money, and we found a dispensing clinic that gives medications to these folks for free. She filled her medicine. So even the ways that we're approaching the analysis of the data, so many meetings I've been in where the data wonks are just pounding the table about we don't have enough data, it has to be these big longitudinal studies and that. I just don't believe that. Mm-hmm. If somebody's hungry and you feed them, that's a data point. And you can measure what happens in their use in the emergency room and extrapolate that outcome to the health plan or state that's trying to pay for this. So anyway, I kind of give the dark and the light answers to
no, and they're both right? I mean, I think we've got some plans, some payers, and some health systems that have started to screen. So we've got there's a set of screening tools out there. I didn't tee this question up for you, but I think you can follow me. We've got screening tools out there that are in use in places by places like ProMedica, for example, where you can identify, at least at a single point in time, what an individual's risk factors might be along this sort of spectrum of social determinants of health. So are they food insecure? Do they live in a place where there is general lack of safety? And a whole host of other things. Do they have transportation challenges that might prevent them from fully and adequately accessing health and medical services? Where do we store that data? And this is, again, I want to bring this down to concrete discussions. We've got EMR, and I'm a former OMB person. I know that we spent $60 billion high-tech money, implementing EMR system and EHR system. So it's not like we haven't tried something big before. What do you see health plans, payers, and other entities that might be, finally sort of moving down this path? What do you see them doing when they've now implemented things like screening tools or other interventions to start to get at, again, data on social determinants of health? I know, I did not prepare them for this. So
all right, I'll get started.
Go ahead.
All right, so I think it's absolutely a great question. I do think that the data architecture is going to look different. I agree with the point. EHRs were really not meant to house this data. I think that calls for a fundamental sort of redesign of the way EHRs work. That's not going to be cheap either, and I think will be a real challenge. I also, though, just to add a little bit to this, I think we are not clear on what questions to ask patients, right? So when it's very sort of top-down driven. We all, I think, in the room understand the necessity of access to food and access to transportation and housing. Those things make logical sense. They've bubbled up to the top in a lot of different analyses. And so I think probably we can design good screening questions around things that we know about. But my bigger concern is that there's a whole host of SDOH basic determinants that we don't know about, that we don't think about, because we are not at risk for those things, right? The folks in this room don't represent the populations that are most vulnerable generally. The most vulnerable populations are not part of the discussion. So I'll give you just one story to illustrate the point. When I was in residency in Philadelphia, one of the requirements of the program, and this was totally agreed way before we understood or started thinking about social determinants in clinical life, but one of the things that we would do is ride the ambulance, for a month essentially with EMS and paramedics to see what your patients were like in the home environment. And I will never forget walking into the home of a patient that I saw repeatedly in the ER, labeled a frequent flyer, with congestive heart failure that was going to get admitted. You knew every time you saw her, she was going to be in decompensated heart failure and was going to be admitted. And what I saw in her home in a really hot summer day in Philadelphia was a home with no air conditioning that was basically falling apart. Every single window was open, and she was sitting in front of a table fan in order to just try to keep cool. She wasn't moving around. She wasn't preparing good meals for herself. She was probably barely taking her heart failure medications. And that was incredibly impactful to me. So it taught me two things. One, I think we got to get into our patient's home. It taught me a ton of empathy for her, because I would not view her the same way when I saw her in the ER again. This was not a willingness problem. She was not, she didn't not care about her health or about herself, all the things that we can assume when you see a patient over and over. But it also taught me I don't know what questions to ask somebody like her. Do I ask every single patient that I see, do you have air conditioning in the home? Do you have fans? How do you keep cool? These are not questions that I think occur to most healthcare professionals. That is, I think, the deep concern that I have is we just don't know how to screen, and it's because there's a basic class divide in healthcare itself.
I couldn't agree with that more. And I think it brings up an interesting point here, which is the risk of, and I know you all have talked about this before. I was reading the notes from your last meeting about medicalizing what we're trying to accomplish here. Although the work is fantastic and a lot of organizations are leaning into this, a great example is, for some reason, ICD-10 is now the place where we're going to codify social determinants. I don't know if any of you have been in the world of billing, but we used to call these Z codes trash can codes 20 years ago, because if you didn't know where it went, you put it in a Z code. And I'm not suggesting that's what's happening now, but to give some contrast to this, how many of you have heard of the Ayers taxonomy? Like 3 people.
More people heard of NQF. That's bad. That's bad.
I'm winning right now. So here we have this big effort from the AMA to Cigna to everybody and their mother trying to use the ICD-10 medical perspective of social determinants. And there's a group out in Los Angeles, sponsored by the United Way and 211, that has been developing what they call the Ayers taxonomy for 20 years. There are over 8,000 entries of social determinants in the Ayers taxonomy that not just talk about housing insecurity in a survey, but there's 87 reasons you can be housing insecure. And so my point is that there are resources outside of what we normally can see, where people have been working on this for a long time. All to, I think, the bigger point of outcomes and building these longitudinal social records that people need, that we need to measure and manage and drive the kinds of value for our invested resources that we all need to be able to produce. If we can't tie this data structure, data work, community activity to outcomes, then none of this will ever be sustainable. And the outcomes goes to everybody. Health plans need outcomes to be viable. Community organizations need outcomes to show their funders that they are achieving their mission or no more money. And most importantly, this lady in Philadelphia needs outcomes, big time. She doesn't need to be sitting in front of a fan. So the idea of a longitudinal social record is something that doesn't exist today, and it's what we're driving toward. It exists in an EMR, sort of, but the analog where we have longitudinal clinical records, we should also have longitudinal social records. And I know I'm taking too much time, but back up and kind of finish with this. If we could magically go back 50 years and take another run at this, we would never have an electronic health record. We would have a whole person care record that would accommodate all of this if the incentives had been there in the first place for us collectively to think about it like that. Well, now we have to back into it, and that's the challenge that's ahead of us.
For those of us who've been around for a while, we've got a few stories or some of those moments where you encounter an individual or you learn something as you're doing data analysis that sticks with you. And your story reminded me of one of my moments. I did my postdoc at University of Chicago, so in Hyde Park. We noticed every Friday in the evening, there'd be a slew of older adults coming with other older adults to check them, to admit them to the hospital. And this was not in the literature, it's in the literature now. We now know what it is, basically. But weekend check-ins, basically. The first thing you noticed is that the caregiver, was also quite old and often quite frail, as is the person who's being brought in to be admitted to the medical center. And we now know that, again, as we think about social determinants of health, we're often talking about maternal mortality, infant mortality, maternal outcomes, especially as they relate to, say, African American women. But in the aging population, we have an acute set of crises, loneliness being one of them. Children living quite far away, which is a departure from how we've lived historically, where daughters or children living close by tend to matter quite a bit. And of course, the caregiver being a frail older adult themselves, which can have unbelievable effects on just the general, wherewithal within of the folks in the household. So how does the health system capture that data? And I don't know if TAVHealth is doing anything remotely close to something like this, but how do you go from data like that to analysis to make sure you're answering the right questions, to then doing something that's actionable, or to acting on that information? I want to tee that up for you, Jamo, and then Shantanu, perhaps what you've seen from the NQF setting.
Sure. Well, I'll just quickly tell you the story of our organization. We started when Don Berwick came into CMS and brought with him this idea of the triple aim, which is where the name of our company comes from. And so within the triple aim, which was new to healthcare, but not new to anybody else outside of healthcare at all, what were the seeds of value-based care? And our thought was, if this value-based care thing is going to work, then we're going to have, the clinical world is going to have to follow people home, because we're at risk for them. We're going to get them out of the hospital quicker, but the next 89 days for a bundle, or whatever the risk is going to be, we have to know the life circumstances in which these folks are living, the fans that they're sitting in front of, and manage that risk. So the good news was that we knew there were community organizations in every community that they're doing this work today. Many of them are already funded. We just aren't connected to them. So this ought to be pretty straightforward. This is what we thought 8 years ago. And we said, we're just going to connect all the community organizations because they know each other, they talk a lot, but they don't communicate in a very systematic way that we can manage and measure. So that's what we did. We built a collaboration platform for community organizations and thought that would be the end of it. And we ran into 2 brick walls. The first brick wall was that the social determinants that people have, they don't come one at a time. And there's a lot of conversation, we're going to solve transportation. We're going to solve food insecurity. These are noble goals, but if you talk to somebody, if you talk to a mom on Medicaid who's pregnant and is a high risk for a NICU baby, a high cost delivery, and you say, well, I'm a hospital and we're going to send a car for you so that you'll go to your prenatal appointment. And you look at your data and they don't get in the car. Well, let's go talk to her. And so what she'll tell you is, you never asked me if I'd get in that car, and let me tell you my life. I have 2 other kids under the age of 3. If you think I'm taking those babies to sit in a clinic for 6 hours, that's not happening. And if you think I'm going to leave my kids at home, and I live with my grandmother who's a dual eligible on dialysis, that ain't happening. So it turned out, much to my surprise, because I just didn't know any better, in the world of clinical medicine, we have something called comorbidities. That somebody comes in with a big diagnosis and they have a lot of things wrong with them, and we assemble a team and we solve a lot of things. That turns out to be the case in social determinants of health. There are social comorbidities. And if you send Uber to pick somebody up and you don't ask them why they need a ride, there's a pretty darn good chance they're not getting in the car because you haven't developed their kind of social diagnosis, this system problem in which they live. So that was the first thing that we had to get our arms around, that social determinants are really comorbidities that are outside the view of the clinical world. The second problem that we ran into was, how come you guys won't share information? Everybody wants them to get better. And that's when we realized that the world beyond HIPAA is really, really complicated. Everybody talks about HIPAA in healthcare. That's baby food. Every state has their version of confidentiality rules that these non-covered entities, community-based organizations, have to abide by. And even in the federal world, HIPAA's one piece of the puzzle, right? For those of you dealing with the opioid crisis, there's Part 2, FERPA for kids, the list goes on and on. And if you can't offer a safe way for people to share the right information with the right person at the right time, they won't do it. And so that's what we built. We built a sharing platform that modeled all of these state and federal rules that allowed a longitudinal social record to begin to develop from these community collaborators that now the health plans and providers could tap into and say, she's coming into the emergency room and part of her treatment plan can come up with the most elegant clinical plan in the world. But if I don't get her an air conditioner, if I don't turn on her electricity, if I don't do 6, 7, and 8, she's going to solve those problems in my emergency room. So tying together these community collaborators in this alliance, this fragile alliance, and I'll put in a plug for Governor Levitt, who ran HHS, and his partner Rich McKean wrote a beautiful book about alliance formation that I encourage you all to get if you're interested in this. This was the problem to be solved: privacy, social comorbidities, and collaboration. And when you did that, what you got out of the data was outcomes. And when outcomes came out of the data, guess what everybody did? They ran toward collaborating because it was good for everybody. The only losers were the people that were benefiting from the fee-for-service world, and they hate this stuff. So anyway, that's how TAV accomplished what we did. It's all about outcomes.
Wonderful. Now, for Shantanu, I'd like to hear you talk a little bit more about, you've dealt with these issues as a clinician. You've certainly touched quite deeply on these issues as a government official. But now you're sitting as the head of NQF, and you've got a sort of a bird's eye view as to what other lots of healthcare entities are doing. Can you talk a bit more about what they're doing and how they're leveraging data to address these issues, but more importantly, shed some light on how this is being done in a value-based, and value-based payment system era?
Sure. So I think your last answer was actually really complete. I appreciated it. We are, on the healthcare side, I think really at the start of a journey that community organizations and others have been on for quite some time. But to your question, I think we as an organization are trying to facilitate a few things. First, in the measurement space, to really help develop those outcome measures that systems and communities can track to assess their impact. So, for example, we're doing that in food insecurity. We're working with a national payer, Humana, to develop exactly those measures that they can utilize across their network to both identify food insecure beneficiaries and then track the interventions and how well they're working. And these are they're not really sort of clinical outcome measures. I do think there's clear overlap with clinical outcome measures like how well diabetes is managed. If you've got better access to better food, you can look at clinical sort of end outcomes of diabetes like amputations and eye issues, et cetera. And there are systems like Geisinger that has a food pharmacy that is really looking at those kinds of clinical outcomes. I think that's really important and critical, but there are probably a set of social outcomes that need to be tracked alongside them to really understand the impact that a given intervention is having. So that's an example of a project we're engaged in. I think you could do similar work around transportation, around housing. Again, my sort of previous concern that we are focusing on the things that we know to focus on and that in part, I think some of our interventions are driven by what we can do, right? So we provide transportation services because Uber and Lyft exist. That's great, but it's not nearly the level of specific information and data that you are describing, which I think is absolutely critical. To your question about value-based arrangements, one of the things that unlocked this whole field, I think, for healthcare is the fact that we could enter into alternative payment models, right? If we could track away from fee-for-service, which is inherently confined to delivery systems for the most part, then it opens the door to being able to address a wide range of other issues. So you're seeing that in Medicare Advantage now, you're seeing it being done through CMMI and on the private insurance side. I think that has really opened the opportunity for creativity. We're holding a payment summit to go directly at that issue. So later this year, we're doing a big convening of both community agencies as well as payers and others and providers to try to surface again what has worked. So there's a lot of natural experiment going on, across the country, both on the public and private sector sides. And I think through data, through the evidence, and through some best practice sharing, we can help to surface what does work and try to get this, the system at large to agree that those are real solutions and kind of coalesce around them. So again, I think these are really important steps, but it feels very early to me. I think we need to see a lot more examples of different systems trying to take on different social determinants with a whole host of approaches to really provide the natural data for what works, and that can then be nationalized.
Thank you. I wanted to open it up to the audience. I should have said this earlier, so you can start to think about your questions. But if you have any burning questions, we've got a few minutes, and want to give you a chance to ask those and have our panelists weigh in. If you do, just put up your hand. I don't know if there are mics going around, but if you shout the question, I can repeat it. Go ahead.
Hello, Layla.
I love your notion of clinical record, social record, and these things should be used. So it makes sense that clinical record
Let me repeat her question for for
Good, because I
those
need
who
time to
did
think
not-
about it.
Good. That's exactly the idea. So your question, and what's your name?
Sorry, Layla Noruzi with Aetna.
Great. Layla with Aetna asked that she agrees with Jamo's suggestion that we've got a clinical record, and because of the way the healthcare system is constructed, we know who owns that. He is suggesting that we also need to create a social needs record of sorts. But because, again, we're bringing this discussion is being held in a healthcare arena, right? This is a health policy conference. And so we're by extension suggesting that we would own the social needs record of sorts. Is that correct? Is that the right approach? Or should we be thinking about something else? It seems like I've paraphrased a little, but it gives them some idea. Okay.
Yeah, I owe her one. So the owner of the longitudinal social record is the person about whom the social record exists.
There you go.
Period, full stop. The good news is that there's already an example in use today of how this can happen. And shockingly, it's in healthcare. That is the record of your prescriptions, and they travel with you as you go from United to Aetna, always back to Aetna because Layla's from Aetna. You leave, but you go back to Aetna. Your pharmacy record travels with you, and when you go to Walgreens or CVS, always back to CVS now, that pharmacist can pull up your longitudinal pharmacy record and know, I can't fill this prescription because you just got it filled yesterday at another pharmacy when you were at another health plan. So there is a fascinating alliance that formed. And as a matter of fact, it was under Levitt that this happened, where the group of competitors came together and said, if we don't share this information and let it flow between us, people are going to get hurt. And so SureScripts came about, a not-for-profit that really drove the creation of a longitudinal record that belonged to the person. It traveled with them, but it was shared by collaborators in the community that were even competitive. So standing up something like that again for a social record is daunting, but my point about using the SureScripts as an example is we've done this before. And there's no reason that we can't do this again. And I argue that the tailwind that we have to do this is economics. As you suggested, the payment models are showing up that are forcing us to think about these kinds of solutions. We don't need to reinvent it. There's people that have already figured this stuff out.
Let me just add to that point. One of the SureScripts is actually the perfect example. And the reason it exists is because healthcare entities recognize the inherent risk in not knowing their patient's pharmacy background or what drugs that they've been taking. And so I don't know if you all are familiar with SureScripts, but it is basically as complete a set of data as you can have on an individual's prescription use, prescription medicine use over basically since they started to interact with the healthcare system. So it brings up a point that I think we don't often raise, which is, do we actually truly have the buy-in across the board to address social determinants of health? I think we've heard a lot, there are lots of meetings now in the health policy space, in the healthcare practice and provider space, but I don't know that the buy-in and the willingness to invest in what it would require to actually address some of these issues is as complete or as universal as we would like to think. So I don't know if you want any other questions. I'm just looking at the time. We've got a minute and a half. Any other burning questions? Go ahead.
Hi, my name is Deborah Lipson. I'm from Mathematical Policy Research. I've been working for the last several years to develop measures for the Medicaid population. And when we bring those measures to National Quality Forum committees for potential endorsement, we've run up against a problem over and over again, which is that, and many of them, by the way, do address either long-term service and supports, which by definition deal with housing and nutrition and other social supports for people with disabilities, Or they're, we call them what, the high flyers, the people who come back to the emergency room over and over again, which deals with many of these social determinants. And we've been told over and over again, well, you know, Medicaid data, it's different from all 50 states, and it's just not reliable. And until that Medicaid, you know, data gets better, then I'm sorry, we just can't endorse your measures. So what are you doing at NQF to try and help those of us
You
who
wanna
believe
take that one?
that
It's all
Medicaid,
yours, man.
You should have
All yours.
expected.
Oh, God, I'll talk about it on the
with
spot.
its gold seal of approval
Yeah.
for these measures that deal with the Medicaid population, which has some of the most, critical SDH issues. How can you help us? Thank you.
It is a great question. So first, our process is meant to be, as you know, Mathematica goes through it for a variety of measures all the time. Our process is meant to be very rigorous, right? And there are some really basic concerns that our committees, and this is just for folks who may not know, we do all of our endorsement work, which is essentially the measure review work and the certification work, through multi-stakeholder committees that in the case of Medicaid measures is comprised of Medicaid experts, clinicians, payers, others, et cetera. And it is a long-standing concern about sort of the homogeneity and the reliability of Medicaid data. It's very hard to get past that because in terms of measure certification, in order for that to mean anything, we've got to make sure that measures are valid, they're reliable, that the data behind them is accessible, that it's a useful measure. And whether it's readmissions or measures tied to the social determinants, Medicaid measures, I think, inherently face an uphill challenge because of the quality and the interoperability and the reliability of the data in Medicaid. I think that is just unfortunately true today. I don't want to suggest to you that it's more optimistic than it is. I think that's the state of reality. But I do think it's getting better, and as it gets better, my goal, certainly as the head of the organization, is not to change our standards around different kinds of measures. I think we can take innovation really seriously. We've implemented new things like a scientific methods panel that is charged with assessing new measures and new methodologies, specifically so that we're not squashing innovation. But at the same time, I've got to maintain a really high and rigorous standard. Otherwise, when you do get your measure endorsed, it won't mean a thing.
Right.
So better data for Medicaid, absolutely. We need it. I hope, when I was at CMS, I directly contributed a portion of my budget to get better data from the states. A lot of us did. I think they're making progress, and I hope that really does happen and that data comes out into public use, because we'll be a primary user of it then. And second, we're doing a lot of work in social determinants. We're trying to push developers like you and others to get access to better social determinants data incorporated in your measures. There's a lot of learning to do there still. It's a work in progress.
I don't know if so we are out of time, but we are going to be hanging around, so please feel free to grab any one of us. I want to thank our panelists and to the Alliance. Thank you so much for this session.